Acetic acid is applied to the skin surrounding the suspected lesion. The application of the acetic acid over this area will allow for the affected area to be more prominent due to redness that will occur after a few minutes. Being pointed out now are the margins of the lesion, which are determined once the acetic acid has had some time to work, and can be seen as an inflamed area against the surrounding skin. Take note of the inner labia being grasped, as well as the urethral opening. The skin is marked, making sure there is a good margin of healthy, unaffected tissue that will be included in the incision. The skin is incised along the markings. Take note of superficial bleeders which are cauterized along the way. A good margin of healthy, unaffected tissue should be included in the incision, resulting in an elliptical-shaped incision. Countertraction may be applied on the skin of the defect to facilitate the incision on the subcutaneous tissue. The subcutaneous tissue is incised in line with the skin incision, again using the diathermic scalpel. Care should be taken to avoid the urethral opening if possible. The depth of the incision depends on the origin of the lesion. In case of malignancy, it should be at least 2 cm deep. In a pre-malignant case, as shown here, the dissection may be more superficial. The specimen is dissected until it has been freed and removed from the body to be sent for pathological assessment. The defect is examined for hemostasis before the closure can commence. Small bleeders are coagulated using diathermy, but a single suture may be applied to stubborn bleeders until the surgeon is happy with the hemostasis of the defect. Once hemostasis is confirmed, the closure may commence. Take note of the vaginal opening, the urethra being pointed out, and the margins of the defect that will now be closed. The skin to be closed by primary wound closure is determined by approximating the skin to assess the degree of tension on the wound. The skin on the upper part of the wound is closed, making sure there is minimal tension on the wound. At the point where tension begins, primary closure stops, and closure using a local flap is advocated. Vertical mattress sutures is preferred due to its ability to achieve precise vertical alignment of the superficial wound margins. Care should be taken to avoid the urethral opening during the closure, which is now being pointed out. The tissue should be sutured carefully, making sure the urethral opening is not included in the closure as far as possible. Here we see the tension-free primary wound closure of the upper part of the wound. The primary wound closure is also performed on the skin of the lower part of the wound, in a tension-free manner, again using vertical mattress sutures. Here we see both the upper and lower part of the wound that has been closed by primary wound closure in a tension-free manner. The outline of the VY-plasty that will follow for the secondary wound closure is marked on the skin. First a square that fits the defect, then a triangular top is marked. The skin is incised along the previously made markings. The subcutaneous tissue is incised in line with the skin incision. Note, the diathermic scalpel should be pointed away from the flap to avoid undermining it. Holding the scalpel towards it will undermine the flap and potentially injure perforators vascularizing the flap. Take note that even though the skin of the defect seemingly shrinks, it maintains its flexibility, which will allow it to close the defect on all sides. The skin is closed, and this is continued all around the wound until the entire defect is closed. Again, mattress sutures are being used. This is the completely closed defect. A catheter is inserted and kept in situ depending on the healing of the wound.